Good morning, dear colleagues, and a very warm welcome to the second episode of Conversation with Professor Chintamani. He has been a role model, a leader, a guiding light to innumerable students, and who has beaten the odds to grow as one of the greatest lifesavers of the country. He has been an inspiration to many young surgeons. He has spent decades of his career to serve the poorest of the country. I extend a very warm welcome to him. Sir, a very good morning to you.
Good morning, Sukriti. It's a pleasure. Thank you.
So there are many questions which have been put by the surgery residents as well as undergraduates on our YouTube channel as well as in the group. Because they all seek answers from you, and I request you to take these questions and answer them for the benefit of all.
Surely, Sukriti, and I think we're doing a webinar after a while now. It's been some time. So this webinar would double up as the answers to the questions, and we'll probably, hopefully, take some cases also.
Yes, sir. We'll take one.
Well, it's truly a joy to be sharing my ignorance with all of you. We will just be getting on with some of your questions, which are very, very interesting, and I'm glad you asked questions. And before I move on, a lot of effort has been put on by my very dear student, Sukriti, she's here, who's made it possible for all of you to interact with each other, and we are looking forward to more questions and more answers in future.
So the first question has been put by Aman Sartaj Khan from DY Patil Hospital, who wants to know what is PET racist criteria.
Aman, that's a very good question, and I think it must be Aman. If you're pronouncing it wrong, please forgive. I'm sure that's a very important question, and you're probably referring to it in connection with the soft tissue sarcoma case that we had put up, where we mentioned about the use of PET scan in these conditions. You know, there's an article of mine, if you're interested, you can read. Can you bet on PET? It was an editorial that I did some years ago for the Indian Journal of Surgery. That's on PubMed, and you can actually go through it, and some of the questions would be answered. And it's for the benefit of all the students that it'll give you a good insight into PET as a tool which can cause problems, it can solve problems. So you should understand it from both angles. Now, to answer your question, first of all, you need to understand what is racist criteria. Now, whenever we put a patient on some kind of a therapy, it is mandatory that we assess the response, because if we don't know whether the patient is responding or not, then we may unnecessarily be giving the drug which has a lot of toxicity. All cancer agents have, cancer therapeutic agents have morbidity attached to them, so therefore you should be extremely cautious that you're not giving a very high dose to patients who don't need it. So you need to, whenever you're putting the patient on any kind of a therapy, a question is asked, whether it's asked or not, it's mandatory to know whether the patient is responding to it or not. For this we have various criteria. There was earlier a criteria that was called as WHO criteria, where what do you actually look at? You look at a tumor that has been put on some therapy. Now, how much does the tumor shrink? And people would generally assume, I'm not trying to say it's always the case, if the response is more than 50% reduction from the original tumor size, we'll take it as a response. So if you were to broadly divide the patients into two groups of responders and non-responders, those where the size reduces by more than 50%, they're responders. Where it does not, they were non-responders. Then people fine-tuned it even further, 75% response and above, they were taken as near complete response, and 100% the tumor disappears was taken as complete clinical response, or CCR. These terms are necessary before you move to understand the racist or the PET racist criteria. So please understand this very, very important aspect of assessing response. So broadly speaking, therefore, if the tumor shrinks from 5 centimeters to less than 2.5 centimeters, we take it as a response. Now, your question can be after how many cycles? Generally, we assess response after 2 cycles, 2 to 3 cycles generally. And if the patient is not responding to a particular regime, we have an option to switch on to a higher regime or a second line therapy. So it's useful in planning your therapy and changing it if required. Now, so how would you measure this size? One is you clinically measure it using ultrasound, which is a good extension of clinical examination, and you know the size is accurately this much. Very often, say in breast, when you're palpating, you may get a lot of breast tissue around the lump, so you measure wrongly. We have, in my triple assessment talk, if you pay attention and watch it carefully, I've shown the use of vernier, the use of calipers to measure the actual dimensions. Earlier, what we were doing, we were taking two x's and drawing out a median of the two to find out what is the size. Now, then after two cycles, measuring the same to see whether it's responded or it is reduced by more than 50% or not. So that's one thing. That was called WHO criteria. Now people thought that this is very cumbersome because you need to have two x's done, then you need to get a median. It was cumbersome. So to solve it, they came out with what is called response evaluation criteria in solid tumors, which is called RACIST criteria. Response evaluation criteria in solid tumors. So all solid tumors, if you're putting the patient on some kind of a therapy, you can use this as a criteria, right? So what do we do here? We just measure one axis, but then you better be accurate because you have a chance of getting it wrong. So people used imaging and they made imaging more sophisticated. And MRI, if you again go through my triple assessment talk, I have described the role of MRI. It's a very useful tool, and I'm recommending to all those who are listening right now, please watch that triple assessment talk. It's very useful for all of you because that forms the basis. Maybe it's a little longish than we would have desired, but then naturally it has more information, so it has to be longer than usual. So people used MRI and they were measuring the response by just getting one dimension right, one axis right. And if one axis is accurately taken, you can get an assessment based on whether it reduced beyond 50% or it did not. That's called response evaluation criteria in solid tumors. Non-responders are to be defined. Others are all responders. What are non-responders? If after your desired cycles, that I mentioned two here, it can be three in some studies, they've used three. If the tumor size remains static, or it progresses, or it doesn't reduce more than 50%, we'll take them as non-responders. So the response is not merely just one part of it, right? I hope that is clear. It should reduce by more than 50%, that's most studies. It should not progressing, I mean that's naturally not a responder. And even if it remains static, it is not responded. We wasted time. So it's very, very important to use it. Now, so that's RACIST criteria. Now, what are we measuring here? We are measuring the T size and the reduction in T size. T and M is what reference I'm using. So T size, that is tumor size, reduction is what we are looking at. But that's an anatomical observation. It is possible, and it happens, that you have a tumor that has responded, it has died completely inside, it's all fibrous tissue inside, but the size remains the same. So it is anatomically not responded, but biologically it is responded. So in some tumors, I'm not recommending that, that's not a routine. You can assess the biological activity also, and we all know that PET scan is a good tool to assess the biological activity, where you're using the FDG and fluorodeoxyglucose, glucose, where you're looking at the isotope getting into the metabolically active cells. And in my article there, if you read, I've mentioned the pitfalls with PET scan. That is, you even a inflammatory lesion, chronic inflammation, granulomatous conditions in this part of the world, especially tuberculosis, picks up the activity, and you can confuse it with malignancy, and you can actually upstage a disease, which is a shortcoming of PET scan. But if you have an established diagnosis, to use PET scan for assessing response, what do? You have a PET assessment before, you have an anatomical assessment before, then you have a PET assessment later on, and an anatomical assessment subsequently. So the two can be clubbed together to get an even sharper idea of response, the response evaluation. We call it PET RACIST criteria. I hope that's clear.
Thank you, sir. That answers the query for many of the students. The second question has been put by Dr. Milan Bagazia, and he would like to know about the upfront chemotherapy for breast cancer. And the second question from him is about the management of bilateral breast cancer. If it's a synchronous or a metachronous breast cancer, then how do we manage such patients?
Thank you, Milan. I think your question is very good, but you used a term which is a very crude term, upfront chemotherapy. I am sure you are looking at chemotherapy as the first modality. So first of all, let's get these terms sorted. There is confusion as to what you're using. If our primary therapy in a particular cancer is surgery or radiation, I'm I'm being very clear. So don't use terms like upfront chemotherapy. That's a wrong way to use it. Now, if my plan is surgery or radiation as a primary treatment, but I find that I may not get a clear margin, or for whatever reason, I want to put the patient on some therapy before surgery or radiation, as I mentioned, both are cutting arms. We will call it neoadjuvant. You try using these terms. So neoadjuvant, neo means before, so neoadjuvant chemotherapy would be what you are trying to say is upfront chemotherapy, because there is nothing like upfront chemotherapy otherwise. The neoadjuvant chemotherapy is used in order to make a tumor resectable. And when I am using the term resectable, I am trying to get an R0 margin, which means I should get a microscopic freedom from the disease following my surgery. And I don't think I am able to get it with the tumor being large or the margins being difficult to get. So I'll put the patient on some kind of a therapy, which can be neoadjuvant chemotherapy. It can even be neoadjuvant radiotherapy. There's nothing like neoadjuvant surgery. That part, please don't get it. Upfront surgery is the correct term, but upfront needed chemotherapy is no such term. There is nothing like upfront chemotherapy. So neoadjuvant chemotherapy or induction chemotherapy, they can be used interchangeably, although there is a difference. When you're putting the patient on neoadjuvant chemotherapy, we can do induction. Induction means you may start with a slightly lower dose and induce, or maybe with, I mean, for you it is important that you understand that my purpose of putting the patient on chemotherapy is not to cure him with chemotherapy or her with chemotherapy, but to make her or him amenable to surgery. So that will be neoadjuvant or induction chemotherapy. So that's one term which probably is getting confused. Now, what are the other advantages of putting the patient on neoadjuvant chemotherapy? You're referring to breast cancer only, but wherever the term is used, I'm extrapolating it for the benefit of all the students. But say breast, it will make a non-resectable tumor resectable, which is a broader use. Secondly, it will make it feasible and possible to do breast conservation surgery in some tumors that are slightly larger than usual, but they would be ready for, because I'll be able to get a good margin, and I can if I can achieve a good R0, and also the tumor breast ratio is good, I can offer the patient breast conservation surgery. So that becomes an option. The other thing which is very important is that it provides you an in vivo chemosensitivity test. What does that mean? For the benefit of all students, which is all ranges, the UGs, PGs, and everybody. So they are all going to be asked this, and they need to know this. So which crosses about 1,300, 1,400 students. So they should all get this clearly. It is also to get an in vivo chemosensitivity, which means I would have tested that this therapy is going to be effective, so that I can use the same therapy subsequently. If the neoadjuvant chemotherapy has been used, I can use the same regime subsequently. So it provides me an in vivo chemosensitivity test. Do you understand how useful it is to have the intact tumor? It's still within the body, and we are able to get a response assessment. So we know this therapy is going to work. Third is It will take care of the micrometastasis if they are there any, because most patients in breast cancer especially would die of metastatic disease rather than local failure mostly I'm saying. So you must understand the purpose of neoadjuvant chemotherapy, and don't use the term upfront chemotherapy. Hopefully you won't use it now. Now there is a term called as primary chemotherapy. Primary chemotherapy is a term used when actually the primary therapy is chemotherapy. You know, and that's not again called upfront, so don't use the term upfront. I'm repeatedly saying it. I've said it repeatedly. Primary chemotherapy is when the treatment of choice is chemotherapy only, like metastatic cancer. You're not putting neoadjuvant chemotherapy there because your therapy is not surgery. Although it may sound semantics, but it's important to use the right terms. Okay, so primary chemotherapy would be what? I'll put the patient on chemotherapy hoping that this will take care of the disease because it's already systemic disease. Now if after that there is some remnant disease in the local area which needs to be managed, I can do surgery, and I'll call it salvage surgery because I'm not going to salvage the situation. Things have failed, so I need to salvage it. But there's nothing like upfront chemotherapy. Now if I use this therapy after surgery, I'll be calling it adjuvant radiation or adjuvant chemotherapy. Now there is also neoadjuvant radiation in some tumors like soft tissue sarcomas. Sometimes you may use neoadjuvant radiation followed by surgery. But there is also primary radiotherapy where the treatment of choice is radiation, and I do surgery as a salvage. That will be called salvage surgery. So neoadjuvant chemotherapy / induction chemotherapy will be when your definitive treatment is either surgery or radiation. Primary chemotherapy when your definitive treatment is not surgery, it's chemotherapy because it's a systemic disease. And for the remnant or recurrent disease, you're going to put the patient on surgery. You can take up the patient for surgery. So the term upfront should be clear. The second part of the question was bilateral disease. I think we have discussed a case also in the previous webinar, which was put up to all of you, where one side the breast had ER/PR positive and triple negative on one side and luminal A on the other side. Yes, right? That was the case? Okay. Yes, now it's a very big question, and I'll request all of you to also go back and watch the YouTube videos of the past, because the groups keep adding up and you are not exposed to the question that were asked, because this exactly was repeated. But for the benefit of all the other students who joined in later in the group, bilateral breast cancer is no rocket science. You need to look at two breasts as two different cancers, and two breasts as two different organs. Okay, now if I have a lump in the right breast with a node in the axilla, I'll stage it depending upon what it is. If I have a lump in the other breast and a node in the axilla, I'll stage it as right and left and manage accordingly. If I have no primary on the other side but there's a node in the axilla on the contralateral side, I have T2N1 disease here but no T here but N1 here. It will become a metastatic disease. So that part you need to understand. Now naturally I will expect that you'll be watching that bilateral breast cancer case that we had discussed at length. It was about half an hour that we devoted to that case. But since you asked a question, I'll answer. It depends on many factors. Now, not every bilateral cancer is lobular carcinoma, so don't get frantic about it. In lobular carcinoma, we have a rule of 10. What is that?
10. The incidence is 10%.
10% incidence.
10% are bilateral.
10% are bilateral.
And 10% are
multicentric. So incidence is 10%. The 10% are bilateral and 10% are multicentric. The term is multicentric now with a distance of 5 centimeters rather than anything else. So if they are more than 5 centimeters away from each other in one breast. So if it is lobular, we should go for the genetic testing. We should also try and see BRCA1, BRCA2 in these patients for the family tree, and also look for ovarian cancer, and also exclude BRCA1 and 2 related cancers. Take a very good family history in these patients, and if it is triple negative on both the sides, family history needs to be taken all the more strongly, because very commonly they are BRCA1, BRCA2 positive cancers. Now, bilateral cancers, if they are both early, versus if one is early, the other is delayed or locally advanced, or both are locally advanced. These are the three scenarios we can have. The early breast cancer on both sides can be managed by breast conservation if you are using conformal radiation, which means the problem used to be the dose of the routine tangential breast radiation or the external beam radiation would be so high if you do breast conservation on both the sides that it will be too morbid for the patient. So therefore a lot of them would be offered mastectomy. This was the reason. There's something else which is cropping up now which is different. We'll discuss that later. Otherwise, depends on the stage, management would be stage wise the same and treat one breast as one individual. So there is no confusion on that. Now the question comes when you want to do breast conservation on both the sides. Otherwise it's simple. If you want to do breast conservation on both the sides, you need to resort to APBI or accelerated partial beam irradiation, so that you don't have to give a very high dose. It's common sense. If you give a very high dose, you can't give it on both the sides.
Yes, sir.
But if you're giving conformal, you can give it on both the sides. So if you can offer conformal radiation, if the patient is willing to be accepting to be coming for a follow-up, the same indications and contraindications for breast conservation surgery would apply here. So what is special about it? When you're using the term synchronous, metachronous, please, when you're asking question, read what you're asking. Don't just be loose, synchronous, metachronous. This is not a free-for-all. You should understand the meaning of it. Synchronous malignancies are those that happen within 6 months of each other, and you better be very sure that it was 6 months that you found it on time. It's not that you found one late.
Yes, sir.
And then you start counting from the day you found it.
Right.
So it's from the time when the cancer has actually happened. So synchronous is within 6 months. If any second cancer happens after 6 months, we usually take it as second primary or metachronous lesion. There is no rocket science in these terms. Now, especially in breast, since you're talking about breast, it will be in the contralateral breast if you remove the breast on this side. If it happens on the same side, it will still count as recurrence because we would have finished our therapy only in 4 months.
Yes, sir.
So during therapy it can happen, or it can emerge, exactly the case that we had discussed, where the second primary was after the chemotherapy, the patient was actually having right-sided T3N1M0 disease, which was triple negative, left side was no problem. We put the patient on neoadjuvant chemotherapy, patient was coming for regular follow-up, and on ultrasound we picked up the lump on the contralateral side, which was T1 very early and no node. We did a triple assessment like we do each time. We got a core biopsy done. It was a ERPR positive and HER2 negative tumor, no node. So T1N0M0 on left side, T3N1M0 on the right side, and she was a responder.
Yes, sir.
We offered her breast conservation with APBI. She said, I want mastectomy. So both sides can be offered skin sparing mastectomy with reconstruction. Now a lot of patients, especially in USA and in West, are opting for bilateral mastectomy as a risk reduction surgery, although the risk has been exaggerated. If there is a cancer on one side, the chances of the contralateral side getting cancer is about 1 to 2%. That's a CA database. And the same is different for a high risk women, where it will may be higher than usual depending upon the gene panel assessment and the BRCA1, BRCA2 positivity. It can be higher, what is called as an Angelina Jolie effect. Now their patients can be offered risk reduction bilateral skin sparing mastectomy, contralateral, that is one side you can offer mastectomy, and then it is easier to manage because then radiation would depend on the same parameters that we use for deciding on radiation, using the 3, 4, 5 criteria. Grade 3 size more than 5 centimeters and 4 out of 10 nodes in the axilla, although 1 to 4 are also given. This I have discussed again in triple assessment.
Yes,
at length. Please go through all the videos. Don't be choose in pick. Every video has a continuation of somewhere, so please watch all of them. And don't be lazy not to watch something which looks longish. It's for your own good. That's longish. We just expanded the classroom because some of my dearest students, like the one here, they were very keen that the classroom expands. We teach that regularly. So the idea is to make you think more and analyze more. So therefore, don't just write bilateral cancer, synchronous, metachronous. This is not how we go about it. If a patient develops a lesion on the contralateral side, like I mentioned just now, while on therapy or after therapy, it will be a new primary if it is more than 6 months. By definition, that is metachronous. If it develops within 6 months, we call it synchronous. In that case, the management, every time the management is based on the stage and the MDT decision on that. We will be putting up an MDT also on for all of you to see. We just recorded one MDT recently held where you know how the case is discussed and how do we arrive at. Am I okay,
Yes.
Sukriti? It should be there, I think.
Yes.
So, answering it again, suppose the second or the metachronous cancer occurs on the other side. Now your problem would be if you've given all radiation on one side and the radiation is not conformal, the chances are you may not be able to give radiation on the other side. If that be the case, you'll have no choice but to offer mastectomy, even if it's an early disease, like we did in this case, because she could not manage to come for the APBI could not be offered, and plus she was not too keen, and she wanted that. Why should? What would be the result of that? We'll follow that case up. Right side we have done mastectomy. Suppose radiation is given. Left side we don't need radiation. Because after that mastectomy, the patient doesn't need any other treatment because she's fine and we'll treat her. Now the question is only whether she would require hormone therapy or not. Triple negative on one side, she has done well with chemo, which is expected, but ER/PR positive, HER2 negative on the other side. Hormone therapy should do well, so she'll get both. But the options are the same: breast conservation surgery versus and mastectomy. Breast conservation surgery, why probably you're asking this question, I understand, is little, if you do bilateral breast conservation, which is possible, should be done, but then you need to give radiation which is less toxic. The only problem is radiation. And you can't be repeating the therapy just because one breast is treated, now the other breast will get the same therapy. It's not possible. It's too toxic to repeat the therapy. So it will generally be assumed that systemic therapy would be shared, but the local therapy has to be decided very, very carefully. Therefore, if the patient is offered conformal radiation on one side, then it is possible to offer the same conformal radiation onto the other side. Hope that takes care of the question.
Thank you, sir. I agree with you that these terms are very loosely used at times, and you have very accurately defined them for all of us, and I'm sure we'll be very careful from now onwards. The next question has been put by Dr. Farhan Ahmed, who this question is relating to the recent video of surgical clinics with you on retroperitoneal sarcoma, and he would like to know what is treetop mobility, the term which was used in describing it.
Well, that's a very good question. I'm glad you asked it for the benefit of everybody. Now, imagine a tree. It moves, it just sways, but the lower part doesn't move. That's a tree. So many pelvic lumps that are fixed, you can't get below them. They're fixed in the pelvis and they're broader above. And you're able to move them a little bit and you start calling them mobile, while they actually are not. So it's just the tree top, that the top of the lump which is mobile, which will happen not exactly a stalk, I would say, but the portion below is narrower and the portion above is broader, and the above portion is not fixed to anything.
Yes, sir.
So it's a term used for describing a mobility, especially for the pelvic masses which are fixed below, but the upper part may be a relatively little more mobile than the lower part. But simply because you cannot get below them, they are fixed there and they are pelvic masses and they are retroperitoneal. Part of it could be just adhered to the peritoneum, or they are so large that there is a relative mobility vis-a-vis the lower part. See, a tree is not a mobile structure, is it?
No.
Can a tree go walk up to the tree doesn't walk up to any other place, but we can, so we are mobile. Tree is not mobile, then how do you describe the mobility of the top of the tree? That's called tree top mobility. So relative to its lower part, it's mobile, but by itself the lump is not mobile. That case had a very funny kind of a mobility, so the student can get confused that it looks like a mobile lump, but it's a retroperitoneal lump, and retroperitoneal lump is not mobile, it's fixed. Now the argument can then come, if you're calling it a retroperitoneal lump, so I am not calling it mobile, I'm calling it fixed, but there's a portion below which is relatively more fixed than the portion above because it's narrower than the portion above, so that's called treetop mobility. So term is used to describe an otherwise immobile structure which has a part that is mobile vis-a-vis itself, not vis-a-vis the rest of the peritoneal cavity. Now if I have a mesenteric cyst, it moves
Freely.
freely, right? Now vis-a-vis itself also it is moving, but a retroperitoneal lump, especially a pelvic mass, it is fixed lower down, so the top moves like this, and we confuse it to be mobility. So what I was referring to there was that it's not mobile, it's just the treetop mobility you are thinking is the whole lump is mobile, which is not the case.
Thank you, sir. The next question has been put by Dr. Murli in the group, and he asked about the management of a gastric perforation in an unstable patient. What would be the minimum surgery that can be offered? Can we offer lateral duodenostomy, or should we exteriorize the gastric perforation?
This was a question that you had put up, and probably we we try to advise you not to put too many loose-ended questions, and also we didn't want any cross answering, because in the past also we observed that this can actually create a lot of confusion. We need to have some discipline in the group so that we can make the most of it. Although I appreciate your curiosity, your keenness, I appreciate that. So therefore, don't mind. It is just that we have to stick to some kind of a system. Otherwise, it can be all over the place, and you can see that we are trying our best to put as much across as possible. So that's a request, and I would want you all to kindly follow those instructions. Those instructions are basically mine, where I would want most of you to ask questions and nobody else should reply, otherwise there'll be confusion. And this is a classical example of a question which is loose-ended. And the answer has also been given, which is again not based on any understanding of it. I'm sorry to say that. And I hope they will realize that it's coming from their own teacher who's trying to make it good for them. But the question is, what do you do for a patient with a gastric ulcer perforation? Well, that's a very, very poorly asked question. I'm sorry. The question has to be made better. And then somebody replied, lateral duodenostomy, which again is a wrong answer, because you don't do lateral duodenostomy for a gastric perforation. A gastric perforation is in the stomach, and lateral duodenostomy would be another opening in the duodenum. So it is not the best way to manage it. Now, probably some of you, a lot of you must have attended Gurukul master classes, which were earlier conducted in the name of scope. Now the scope is going to be in future it's going to be just Gurukul postgraduate master classes, and what you heard as scope in the past would be Gurukul master classes, PG master classes, for the benefit of all of you. And we will keep it usually with all these examinations and other factors into consideration. Getting back to the question, in the ward rounds you probably heard this scenario, and the scenario was very deeply discussed. And that was the case of a duodenal ulcer perforation, which was a giant duodenal ulcer perforation. And there it made sense. And you must have heard that my resident, she presented with an Apache score. Now you just cannot say the gastric ulcer perforation of a 13-year-old person would be the same as that of a 70-year-old person. The question needs to be qualified further, therefore. And I hope you realize it, and in future you'll put up good questions with good thinking. Now, gastric ulcer perforation occurring in a 70-year-old person may be most likely malignant. Most gastric ulcers perforations are related with malignancy. So if you have to push one cardinal rule through, it is that all patients with gastric ulcer perforation, the biopsy has to be taken from the edge of the ulcer. because they have a very high probability of being malignant. While duodenal ulcers don't need it because they are usually not malignant. Now, coming to the management, if I was to put this question up properly, I would define what is a score. And usually the protocol that we follow, and we discussed it in the ward rounds that happened during the master class, was if the score is less than 10, we try to do primary closures. Between 11 and 20, we do some kind of an exteriorization, and more than 20, patient is too sick to even have a haircut. So we need to optimize the patient so that we can bring the score down to less than 20. How do we optimize these patients? By putting in bilateral flank drains, providing good support, IV fluids, etc. I won't get into the details of it. And when the score drops to less than 20, we'll manage it as group 2. Secondly, when I'm using the term exteriorization, it was in connection with small bowel or large bowel. Now, somebody has answered by saying, we'll exteriorize the perforation from the gastric ulcer. You can't exteriorize stomach. So therefore, that's not the correct way to answer that. Now, what would I do in a patient with a gastric ulcer perforation who is in group 1? Now, group 1 means less than 10. I will close after taking edge biopsy, and probably I'll do a distal limited gastrectomy if I don't have a frozen. With a B2, that is Bilrod 2, that is gastrojejunostomy, and I would not need to do a vagotomy in most cases because cancer cases there is achlorhydria. And also now it is established that with proton pump inhibitors you can achieve the same kind of a response. We have good drugs now. It was the teaching of the past when we didn't have very good medical management for likely stomal ulcers that can happen at gastrojejunostomy if you don't do vagotomy. Now, there was a question in the past that somebody had asked, is there any difference between gastrojejunostomy for a benign condition from that of a malignancy? Well, the answer, if I have to say in one word, there is no difference, but it's an old question. So I need to give you an old answer and a new answer. The old answer is, gastrojejunostomy for benign conditions is mostly retrocolic because we don't want the gravity factor to be taken away. And for that we need to go through the transverse mesocolon, get the stomach and jejunum to be anastomosed, and the gravity drainage is very good. While for malignancy, we do an anticolic anastomosis. This is an old teaching I'm repeating. But there are advantages of doing anticolic in cancer. One, you don't want to open up another channel of spread in the infracolic compartment. And secondly, there is a likelihood that the growth would be closer in the greater curvature. The anastomosis would get involved easily. Now, whether gravity plays a role in the drainage or not, it's been proven that there is no difference. So the answer today is most of the time we are doing anticolic. Nobody would bother to go through that mesocolon. It's cumbersome. Plus, as I said, in a malignancy, it's not supposed to be done. So if you're answering this old question coming from in a fossilized way, your answer would be that gravity drainage is better for benign condition there. But in malignancy, we can't use retrocolic approach because you don't want to open up a channel through the mesocolon. And secondly, the growth, which is in the greater curvature, can involve the anastomosis earlier. And the second is anticolic and retrocolic. They have the same drainage. So that's different. So the first case first, I told you if it's less than 10. If the score is bad, patient is sick and moribund, you have no choice but to do something quickly. We take an edge biopsy and then we do a gastrostomy after freshening the edges, closing it, and having a feeding jejunostomy along with it is life-saving. What is the purpose of feeding jejunostomy here? So whatever contents are coming through the gastrostomy, with the tube can be extended into the duodenum. So all bile can be put back into the jejunum so that we don't have a deficiency of bile in the patient. Bile is carrying lots of electrolytes, sodium as well as potassium. It has immunological qualities, and then the enterohepatic circulation of the bile can be retained, and enteral feeding can also happen with the jejunostomy being in place. So it is in that case that you will be doing some kind of a gastrostomy, which is, you can call it tube gastrostomy or exteriorization of a nature, but if the score is bad. So your question regarding management, please don't mind my saying it, but the question is very, very loosely put, should be very, very clear. what is the age of the patient, what's the score like, all these conditions, to learn to use them. Because you can't compare apples to oranges. The management of the same gastric perforation. You see, gastric ulcers don't perforate normally because the gastric wall is very thick, but they can perforate in immunocompromised persons. The other reason why they don't perforate is because there is usually fibrosis around in most gastric ulcers. And that fibrosis would not happen in an immunosuppressed individual or though somebody on steroids or on chemotherapy where perforation can happen. So it will vary from one patient to the other. So you need to give a complete picture before you ask a question. And for somebody to answer by saying lateral duodenostomy, he probably he confused it with our discussion on giant duodenal ulcer perforation, where I as a protocol we do lateral duodenostomy and a feeding duodenostomy. Lateral duodenostomy keeps the bile out of it and we feed it into the jejunum. So diverticalization procedures can be used in those conditions. I hope that answers it, Sukriti.
Yes, sir. Thank you, sir. The next question has been put by Dr. Naveen, who is an undergraduate, and so he wants to know about the European Hernia Society classification.
Thank you for that question. There are many questions you've been putting, so that's why I thought I'll address Naveen. Don't ask questions that you can find anywhere. This is you just type it on your mobile and you have an answer. There is no such classification that is going to benefit you in the management as far as you are concerned. And don't be too much carried away by unnecessary jiggery pokery of classifications. There used to be a Gilbert classification once upon a time, which was in the Nihas book of hernia. There was an entire book on hernia. So I don't think we'll waste time trying to give you the guidelines and the European Society of Hernia classification. What I'll do is, instead of reading it out and taking away people's time, we'll just put it up on the screen and you will be able to read and find out. So this doesn't necessarily need to be highlighted. I wanted to address this question for specifically making it clear. When you want to learn something, you should be clear as to why do you want to learn it. Now, what is the management of hernia today? Every hernia is managed with mesh. Hernioplasty, whether it's Lichtenstein tension-free mesh hernioplasty or laparoscopic hernioplasty, which is where you put a mesh from behind in the myopectineal orifice. Now their division or their classification is based on this logic because they've understood, now we understand the anatomy of hernia better with laparoscopic approach from behind. But they're comparable recurrence rates with the Lichtenstein tension-free mesh hernioplasty, which can be done under local anesthesia, is resident proof, can be done by most people, easy to learn, easy to teach, with the same kind of an outcome. Many people would argue that laparoscopic hernia repair is only a scope in failed anterior repair where you want to go from posterior side or if there's a bilateral hernia, otherwise it doesn't have any superiority. Now this European Society Hernia Society has brought out a classification, but there is a SAGES classification also, and there is a Hernia Society per se, International Hernia Society. There's just too many classifications. As an undergraduate, I have a suggestion for you. Keep it simple and safe and stupid. Don't try to unnecessarily ask questions or for your own sake or for asking questions for the benefit of others. It's necessary that you should make use of it. Myopectineal orifice is the kind of a passage in a wall through which the inguinal cord, the spermatic cord and its contents get into the scrotum, and the femoral vessels and the sheath get into the thigh. So these are so there are suprainguinal parts, infrainguinal parts, which are all covered in the myopectineal orifice. This is in the fascia transversalis. So we put a mesh now, a larger mesh, and most people are not fussy about this classification. So don't bother too much, but I'll save time by just putting it on the screen.
Thank you, sir. So the next question is by Dr. Patil, and he has asked, how does thyroid cancer spread to the skull, and which layer of the skull is usually involved, and does it breach the periosteum as well?
Well, Dr. Patil, thank you. I think that again, it's a blood-borne spread. It's a hematogenous spread can happen to bones, and skull is also a bone. So there's no rocket science in it. and it's not one layer that's involved. It can involve all layers, and usually it's the bone that gets involved. Periosteum gets stretched, and finally the periosteum also may get involved. But periosteum for a long time serves as a barrier. But it is the same concept. Most thyroid cancers do not spread to distant sites. They usually will be producing the local lymph node involvement first, except the follicular. And a follicular carcinoma, if we can call medullary also as a thyroid cancer, which it is not. So follicular cancer, the old dictum, follicular usually spreads by blood and papillary spreads mostly by lymphatics, is more or less gone now, because we don't divide them into papillary and follicular. It's the follicular variant of papillary. That's how we look at it. But the spread is hematogenous, and it's to the bone. So it can be to the skull bone commonly, to the pelvis, vertebral column, and to the long bones of the body. And it usually involves both the layers. There's no difference. Most of them would get into the body of it first. The pattern of spread is the same as for any cancer that goes to the bone through hematogenous spread. So the question was, how do the metastases go from thyroid cancers to bone? Well, this is usually a hematogenous spread, and there's nothing specific to skull. So don't get confused about it. It's just a bony metastasis that happens to be involving the skull. Now, the other part you were asking was whether it goes to the periosteum first. Is periosteum bone? Periosteum is a covering of the bone, and blood supply to the bone is from inside out. So from Haversian canal system it goes to the periphery. Therefore, periosteum is relatively bloodless. So it will happen initially, the periosteum may not be involved, and it will serve as a barrier to hold it back. And therefore, it can be contained within a very tight compartment. Now, gradually all the layers of the cortex are involved, and that's how it happens. So that probably takes care of it then. So I hope it is clear. There is nothing unusual about it. It's common with the follicular carcinomas, and especially the pulsatile metastasis can come from RCC the same way. Renal cell carcinoma, which is discussed by my postgraduate in the presentation. Whether we took a history or involvement of the kidneys by the renal cell carcinoma, that also can produce metastasis to the bone. And hematogenous spread from most cancers can be to two B's and two L's, brain and bones, and lungs and liver. So these are the sites where it can happen.
So the third part of the question was, does it breach the periosteum?
That I think I covered, because it may or may not. Initially, periosteum is a barrier from outside in or also inside out. That's why in soft tissue sarcomas we often talk of periosteum as a barrier, and if we take the periosteum out, we are quite likely to have a clearance.
Thank you, sir. So the next question is also related to the recent video that we had put about thyroid malignancy with metastasis to skull, and this question is by Dr. Nimesh Tiwari, who wants to know whether we should also do breast examination in this patient, and was there any history of drug abuse which could lead to, just to rule out Hashimoto thyroiditis, and if there is involvement of the carotid sheath, shouldn't the thyroid be fixed to begin with, and it should not move with deglutition? And then also he wanted to know about thyroid paradox, that if the swelling is hard in consistency as it was, then should it not be a benign swelling?
Well, Nimesh, I think your question has four parts. I also happen to read it. First of all, if you really listen to the history and if you watch the video carefully, all these questions are already answered, right? There was a history taken of drug abuse, and who's suspecting Hashimoto's thyroiditis in this case? We have a patient with a thyroid swelling which is odd in consistency, elderly lady with skull lesions. What would come to your mind first? Hashimoto's thyroiditis? Highly unlikely. And even if you take a history of drug intake in the past, Hashimoto's thyroiditis is not always related to any drug. So that part taken care of. Secondly, what is the second part? Carotid involvement. I think you probably got it completely wrong. Please watch the video again and watch it carefully next time. Nobody said carotid is involved. All we mentioned was carotid pulsations are more it's a jumping pulse. We could feel the thrill. There is in fact a hyperdynamic circulation that side. So where is the question of carotid being involved in this case? Nobody said carotid is involved. It's palpable, and we could feel the carotid. We could actually feel the carotid at the same place. And what Sukriti presented was a classical site for presentation was just this. The pulse could be felt at exactly the same place against the Shagnax tubercle, which I actually asked there. So carotid is not involved. I think you probably got confused with that. And there is no question of not moving on deglutition therefore. It's moving on deglutition because it is fixed to nothing. But it's hard inconsistency. And I think this thyroid paradox has gone too far. We had this discussion during the scope. Also I'm being careful now. I must explain things even more because one, that lateral duodenostomy thing came up, and the other is this thyroid paradox. Remember, the obvious hard thyroid swelling is a hard thyroid swelling. The thyroid paradox is sometimes the cyst may also feel firmer or harder because you cannot do fluctuation in a thyroid cyst. It's lying too deep for that. One. Number two, a malignancy of thyroid may feel soft because of degeneration. That's a separate problem altogether. Now, why should we talk about thyroid paradox here? There is no paradox here. It's a hard gland, and it is a hard gland with an irregular surface, which, if you remember, you mentioned nodular. I said no, it is not nodular. It's an irregular surface. Nodular would make it multinodular goiter. And I don't think these questions need to be addressed in that sense, unless you have a huge amount of confusion about. Okay, you said since it is hard, so it should be benign. Most hard thyroid swellings are malignant. Please understand that. But not all hard thyroid swellings are malignant. That's the logic of paradox. Not all soft swellings of thyroid are benign, because they could be degeneration, and that can make it feel softer. So that's a paradox in thyroid. But don't extrapolate and go overboard with this paradox business. We discussed it during scope when it was asked. Somebody asked a question, the faculty asked, what's the thyroid paradox? The paradox is what I've just explained. Now coming back to this case, for a patient to have Hashimoto's thyroiditis, it's a diffuse enlargement of the gland. It is mostly bilateral. It occurs in slightly younger women, and it will not metastasize. So we are looking at a hard thyroid swelling with skull metastasis in an elderly lady. If you don't think of malignancy, you are going too far away from what is actually to be done. Now, a word about the carotids being so hyperdynamic here. This needs to be looked into for certain specific types of cancers, or there is a hyperdynamic activity due to some other factor. But since it is confined to the right side, we could not attribute it to the general condition of the patient. At the same time, there are dilated veins also on that side. You have also if you go back to your medicine book of Hutchinson's clinical methods, the JVP gets raised in right heart failure or right ventricular hypertrophy, or also if the right ventricular, the tricuspid incompetence where there is a backflow, and that can happen. We don't know what is the cause here, but there was a bruit which has been demonstrated in the case. Nobody even once mentioned that the carotid is involved, because carotid is felt clearly. In fact, it's felt more than usual and exactly at its own position. So there's no question of carotid getting involved, and therefore there is no problem with its movement and deglutition. Before carotid will get involved, the strap muscles will get involved. So many other structures will get involved. So it will be a fixed swelling to begin with. It's moving on deglutition, but don't confuse thyroid paradox and don't go overboard making a malignant swelling benign just because in thyroid it's always the opposite. It is not always the opposite. And remember, always is always wrong. Don't get into that confusion that if I have a soft thyroid, it is malignant. If I have a hard thyroid, it is benign. It's not true. The thyroid paradox is a very specific situation which is peculiar to thyroid gland, that a soft swelling may be malignant and a hard swelling may be benign. Is that right? So one doesn't have to use this paradox to make a diagnosis. I hope that stays clear. If it's still not clear, please watch the video again, please watch the case again, and that the history of drug abuse was in fact taken. But I would not be bothered too much about Hashimoto's thyroiditis in this case. Like I said, it would be generally diffuse, and we in fact manage clinically suspecting it to be Hashimoto's based on this history. It's quite unlikely. So therefore, I'm repeating, it's not fixed to carotid. Nobody said it, so don't build it up. Secondly, carotid is clearly felt. It's a bounding carotid. So how can you feel a bounding carotid unless carotid is felt? And if the carotid is involved, you're referring to Berry sign, the carotid won't be palpable. And if that was the case, it would be a much larger swelling than it is. It can't reach there. And carotid was clearly felt. In fact, at one place we have asked this question from the presenter, where did you feel it, how did you feel it? And then we turn the head to the other side to show that even when the gland moves away, the pulsations are visible. That means carotid is where it was, where it's supposed to be. Just that, on the contrary, it is more bounding, right? So don't just get confused, and I hope that takes care of it. I want to address this. I encourage people to ask questions, but please watch the video carefully, and the question should be asked for an answer. So I hope that takes care of it. The paradox of thyroid, I'm repeating, I'm worried that you will probably take it far. It's just a statement that you may have a paradox in thyroid. It's not that you'll always have opposite. You may have a benign swelling which is hard, and you may have a soft swelling which is malignant. But that doesn't mean will be malignant, will be benign. I hope that is clear.
Thank you, sir. And we now have the last question for today. That is by an undergraduate student, Shashi Bhushan, who wants to know how to prepare for NEET PG examination.
Well, like we always say, it's not a coaching group. We are not for the MCQ zombies, and we are not for those who will teach this much is enough. There are 4 questions that have been repeated many times. I personally think good students don't need MCQ coaching. You can make your own MCQs. So it's understanding of the subject that's more important. You're asking my views, so they are not the universal views. So don't get upset if I say that most of these creation of the MCQ zombies is a serious problem that our education system is facing. I understand your problem. Read your subject well. If you know your subject well, barring those stupid questions pertaining to percentage and statistics, and then NEET is not just surgery. I don't know, we have a system of eliminating good people or bad people, but the system is there, and we can't talk too much about the system. It's not that the best people get selected in the best institutes. Sometimes you get very ordinary people getting into big places just because they mastered this trick of cracking the MCQs. So that trick I can't share with you. There's no such trick as far as I'm concerned. When I teach my postgraduates, undergraduates, MCH, DNB students, my motto is very simple: understand your subject rather than cram it up. But sooner or later, even if you get into or you crack down your this PG system, the good news is that NEET is changing towards problem-based questions now. So we are discussing what next scenarios. We'll discuss more of these, and the postgraduates shouldn't get upset when the undergraduates ask questions, because postgraduates might feel we cracked it, so they may not think it is necessary, but undergraduates would ask this question. Now we put what next criteria, the scenarios more and more for you. And in surgery, I don't think if you've watched all these videos and if you listen to all these lectures, you will crack 100%, 100 out of 100, because you would make questions. You wouldn't just be tamed into answering questions. I don't know what you do about the forensic and the PSM and the medicine questions, because I'm not a great fan of the way students get picked up for they crack their NEET exam and get into institutions, because I haven't seen the best come to the best places. So it totally depends on you, but understand the subject. And all I can recommend is one thing: And this is not going to cost you anything, because our entire channel with questions and videos and lectures is all free, so there is no greed in it. So naturally our interest is to teach you. So do not miss out on any of these scenarios that are presented, because this will form the basis of you answering all the questions. Forget about NEET, any questions relating to surgery. But if you were to look at it, it's getting better and it's getting towards problem-based questions and answers. So if you have not learnt it in the clinics, you learn it in these clinics, which we are having, surgical clinics, courtesy all my dear postgraduates. Sukriti's putting all her heart and soul into it, and they've all suffered looking at the way the training happens. They have not, but they've realized that people have. She has not suffered. So we are just expanding the classroom. So attend your clinics, learn from your clinics, even in the hospital. This problem-based answering is not possible with those with the coaching mumbo jumbo. It has to be understood. And I, as a teacher, I've always taught my students to understand. If they understand it, you can answer any question. In fact, you can create your own MCQs, because you need to know the subject. There's no point learning about the GPS with nowhere to go. To be able to go somewhere, you need wisdom also. It's not GPS. It's going to change, and it has changed already. So you'll get problem-based questions. So if you're asking me one way to handle it, the only way I know is watch all the videos, find questions, and ask any question under the sun. It will be answered. Bless you.
We hope that you all enjoyed and learned a lot, and I would really like to thank Sir for his valuable time. So this conversation was very useful, and I'm sure all the viewers they are going to be benefited by this conversation. You all can post your queries in the YouTube comment section, and those who are the members of the group, they can put their queries in the group. And we would request Sir to again take those queries next time in our conversation.
And you can share the videos of the surgery, including the round block that we did in the other case that was
Yes,
done.
sir.
And you can share with them the commando video the case that you presented, which was oral cancer.
Yes, sir.
And do follow it, and I hope you find it useful. Look, our effort is a very humble, simple approach to making things good for everybody. And we don't look at any commercial gain out of anything. So it's a very plain and simple academic activity. And please don't mind if you get some harsh comment from us or something asking you to stop doing something. This is entirely to make it useful for all of you, so that we can have discipline in the group and you can learn as much as we are there to pass on to you. I hope you're enjoying it as much as we are enjoying getting it to you. And
Yes,
thank you,
sir.
Sukriti, for making it possible for all of them to have a good look at the academics that we do. The surgical clinics don't happen, there's no rocket science. They're happening in my OPD regularly. They make a presentation, we record it, we pass it on to you, but it's a lot of effort that goes in. So do acknowledge that effort and feel that you're a part of it. It's an activity that should stay with you forever. We're hoping that will help you build confidence and also interest towards surgery even more. Thank you.
Thank you, sir. Thank you.